105. Shelley, would you do roll call?
Yes, ma'am.
Oh, well, we'll do invocation first. Counselor Buzzard, would you do the
Yes,
blessing?
I will. Dear Heavenly Father, we gather here today to conduct the business of the Cherokee Nation. We ask for your guidance. We also ask for your presence here to make sure that we do what is right for our Cherokee people. We ask you to bless this meeting. We ask you to bless our troops that are serving here and those that are serving abroad. We also ask for traveling grace for our guests that came today, asking them to give safe passage back to their homes. We ask all this in Christ's name. Amen.
Amen. Thank you. Shelley?
Yes, ma'am. Frank Fergus.
Present.
Brian Warner. Bill England. Keith Austin. Here. Jack Baker. Here. Harley Buzzard.
Here.
Joe Bird.
Honey.
Sean Crittenden. John Garvin. Wanda Hatfield. Rex Jordan. Here. Dick Lay. Curtis Snell. Here. Janice Taylor. Here. David Thornton.
Here.
Victoria Vesquez. David Walkenstick. We do have a quorum.
Need approval of the minutes of June 19th.
So moved.
Second.
All in favor? Aye. Okay, we pass. Move on down to reports, and first is Claremore Service Unit. Mr. George.
I think you should have a copy of my report there. You can see outpatient visits are doing well, they're increasing. Revenues are up. There have been several days that we have been actually at maximum capacity in our labor and delivery ward, so that's been a good thing. Several years ago when I got there, we weren't delivering but 10 or 12 babies a month, and now we're up to we're getting over 25 and 30 a month, so that's a big plus for us. We still have some construction projects ongoing. The surgery clinic is I won't quite say ready to wind down, but we're making headway through there. If you've been by there, they're adding on the end of the hallway there an appointment desk, an appointment window. Women's health is still under construction. They're still adding new exam rooms there. The scope of work was sent into Dallas for the emergency department renovation, so hopefully we can get that out to bid, and they said we can expect to hear some news on that within the next 60 days. So that's good news for us.
Any questions? Counselor Lay?
Thank you, Madam Chairman. George, so you've got some docs hired, it looks like, on active announcements for chief of family medicine?
Yes.
Okay. So that's what, 3 or 4?
We have chief of family medicine, chief of surgery, and a staff surgeon. So we've got four openings right now.
So those are opening?
Yes. Yes, sir.
So the revenues increased. Wonder what do you attribute that to?
They're actually seeing more patients. When I first got up there, they had one doc in an exam room, and now we've opened that up a little bit to where each doc has 2 or 3 exam rooms, and it's just a much more efficient way for them to see patients. The screeners and the nurses can have the patients ready for them, so then all the doc has to do is just go from patient to patient to patient. They don't have to stop and wait for them to clean the room up and redo the room and then bring another patient in and do everything in that one room. It's just a much more efficient way to do it, and we're seeing more patients that way.
Thank you.
Mm-hmm. You're welcome.
Thank you.
Any other questions for George? Good report, thank you. Okay, next is Cherokee Nation Health Services. I think that belongs to the IT department.
Okay.
I'm supposed to be leaving that.
I'm suspicious of unattended baggage. What they tell us to do. Before George sneaks out,
Good deal.
we have our signs in.
Yay!
And we're going to send our interpreter signs back to Claremore. We're going to use in this facility. So George, there you go. Thank you to the facility staff, George Long in particular, for overseeing that and getting us turned around. You bet. All right. We're reporting for the month of May. We're going through the report, some highlights again. Something we're all interested in is seeing more patients. And you'll note in our report for ambulatory care visits, almost every clinic is up considerably in the volume of patients. I mean, they are to be commended for the increase. And at Hastings in particular, 4,000 extra patients over last year. That they're all making big strides in the numbers of patients. So we appreciate that effort. That's a total of about, about 8,000 patients more seen this year in May than it was last year. The pharmacy and dental numbers are broken down in the following pages, but a few more highlights. In May, in the emergency room, we saw 6,025 patients. And the report, I'm not sure why Sohel didn't put the exact number on here, but our left without being seen rate for the month of May was 2.6%. And that's below the 3% we've been working toward. That's below the 10% we were at when we first started.
That's good.
So, yes, we have great leadership in Dr. Katie Hughes and Dr. Sharon Smallwood and Tracy Allen in the ER. They're working really hard, so really proud of that. Surgical procedures are going up as well, 417, and we'll have a bigger number to report for June whenever I come back next month. More good news, so we can continue to do these things, is our third-party revenue is finally catching up. And I'm going to go ahead and let you know that our cash flow, the numbers we got last month, shows us on trend to actually be over or in a positive for our budget. We'll not only meet it, but exceed it by hopefully around $3 million. So we've really, I can't say enough for the work of Rick Kelly, Amy Sams, Mitch Thornbrew, and then all the coders and billers, because they are putting in some hours. I mean, we go home at 6 or so. They're there a lot on the weekends, making sure everything's coded and billed and working and getting everything is fine-tuned to make sure the revenue's coming in to continue the services that we're providing.
That's great.
Report on the ACA enrollment. They all stay busy working on those things, and it looks like Vanita and Redbird Smith really knocked it out of the park, signing up 21 and 27 patients. And that what that does is, again, it helps us save money in our contract health services. So we appreciate the efforts of them. And again, our trending diagnosis for the month are hypertension and type 2 diabetes. A few more highlights. At the Salina Clinic, we signed up 19 new patients. At Cooey Scooey, 141. Is there anyone in the community we haven't signed up at the clinic at this point? I mean, they're always just outrageous numbers. Vanita, 102. I'm beginning to think the same about Vanita. Stillwell, 51. They're just doing an outstanding job. We celebrated Hospital Week in the month of May, and we gathered food for the food pantry. It's an employee effort, and we did kind of a construction theme around the hospital, handed out snacks, and expressed our appreciation for everyone. We also celebrated National EMS Week with the EMS group out here. Dental services saw 678, and of those 101 1,133 were emergencies. Public health accreditation, I don't know if this was mentioned last month, but we were recognized for an innovation award by the National Indian Health Board, and they had a meeting in June, and Lisa Pivick and Dr. Sharon Smallwood attended that to receive that award. Now, that's a national award again for our public health, so kudos to that staff for those accomplishments. Contract health, we had 7,483 referrals at a 96% average approval rate. And I didn't get a chance to clarify this number in behavioral health. There's a big gap in that number, but I'll try to clarify how many we actually saw, but well over 2,000 patient visits in behavioral health in the month of May. The other thing I'd like to point out that's in the packet, there's several pages, and the thing I appreciate about Dr. Jones is his transparency with these things. He's been doing these surveys with our patients, and this report is for December into February, and it'll take you a little time, but these are really good surveys. He's included the good, bad, and the ugly comments of patients, and overall you'll see that the comments of the dental services are very, very, very good. So thank you to Dr. Jones and his staff for his efforts there. We also celebrated an appreciation for our providers or our doctors at our annual Our Docs Rock Awards. And just wanted to mention the providers who were recognized for their good service. Rebel Burmaster was recognized. She's from Redbird Smith. Dr. Crystal Phillips in the dental department from Veneta. Dr. Gregory Brooks from Oshaleta. Dr. Tom Kincaid, pediatrician over at Three Rivers. Dr. Pointevine, we call her Dr. P. She's a pediatric dentist at here at Hastings. She does an incredible job. Dr. Sharon Smallwood again. Dr. Brett Gray, Dr. Katie Hughes, Winnie Essex, a nurse practitioner, been very active in the hepatitis C program, and Dr. Henry Smith out of J. Sweet little guy, sees a lot of patients, and he's just very, very kind. The last thing I have, or if you want to have questions, we do have a presentation, if you don't mind, from our behavioral health department. I haven't forgotten.
Let's address questions to
Sure.
you first. Okay, Counselor Bezer?
Yes, Connie, I have a couple of questions. First of all, this sheet here,
Yes.
I was looking at the numbers spent. Some of them had 0 and some of them had a considerable amount spent. And I'm wondering, like J, that's where I'm from, so you got 0 on behavioral health. And I think it's the contract health support cost. And then there's another one like $20 for Stillwell, and Sylvia $0. And then some of them are like 36,000. I guess there's a big discrepancy on contract health spending for that. Am I reading this right?
I'm trying to find it now. This is small print with my glasses. Brett, can you speak to that by chance? Do you have a copy of this? Maybe, I know.
Like
Bring your
Southall,
glasses
they
too.
had like 23,000 spent. They had 0.
I know.
Pretty much this thing, but this is the CAN report. We don't, we use this. This is an Amy Sams does this report. So this is just where it's.
I know. We can ask her for clarification.
Those are the different funding sources, and
Yeah.
so the thing to pay attention to is just the bottom line.
Well, what I was wondering is, we have behavioral health problems in J, and there's no money spent up there.
Yeah.
That's where I'm coming from.
Yeah, I can see that.
Where they're sending them to Hakem. Sorry.
It could be that they're going to another clinic to be seen.
Okay, is that the answer to it?
It could be. Let me clarify with Amy.
And then my question is, why don't we have those people in J, if that's what your answer is? Okay.
Right.
Okay.
No, I understand that.
Okay. Well, Brad, I have another question. I asked this last week, and I forget who was going to check on it. I had, and I don't know if it's a concern or not, Connie, but if you look at the chart on prescriptions. Jay, I'm comparing it with Salina. Salina had a lot more patients, but Jay had 1,222 more prescriptions filled. And I'm wondering why that discrepancy is so much. I know it's going to take some time to analyze why that is. I've watched this for the last 4 or 5 months, and it stays the same. But anyway, when you get a chance to look at that, I'd like to see see if we can analyze and see what's happening up there. Okay? The other thing is the clinic. I don't know, I haven't talked to the administration about it, and I don't know if you have or not either, but we need to do something with the J Clinic, the old Sam Hyder Clinic.
Yes.
I think the furniture, some dental stuff are all in there yet. Is there any plan to get that out of there? Because the grass is growing up around there. We're paying utility bills, we're paying electric bills, and the grass is a foot tall. We have a big need for behavioral health with the treatment center.
Yes.
So something got to be done. So I intend to either talk to the more administration about it or get a board and try to figure out what needs to be done. But
We have
I
our,
wish you'd have some input in it. I'm sure you do. But
we do, we talked about this, actually, Chief and I, before we even built the new clinic, that once it was vacated, we know our need for inpatient treatment
Yeah.
is great.
Yes.
And we've overspent our budget the last several years. And Brett and Sandy Hathcote have worked with Mark Taylor and Joni. We're doing a pro forma or a business plan to see if we could afford to possibly do an inpatient facility at that building. Now, it's going to take a lot of money to renovate it. I think the roof needs replaced.
No, the roof's good.
It is?
We just
Okay,
spent
I've heard that.
$400,000 on it. Yeah.
Okay, well, there's some, obviously there would be remodeling
The inside.
and things like that. But once we get that pro forma done and we can look at it, we may be looking at providing yet another service.
That'd be
Because
great.
our people who need inpatient treatment are experiencing 2 to 4 week waits just to get in. That's how high the demand is. And I think we have the opportunity to be the experts in that. And I'm glad to see you nodding in agreement because the need is great.
Well, it's great. And it's a pretty nice building yet. And like you said, it'll take some remodeling and the money for it. But it just really saddened me to see grass a foot tall.
I'll check with the facilities department, see why that is.
Okay, and then we're paying the utilities on it, paying the insurances on it. So we need to get something done, and I guess probably what we need to do is figure out how to get that stuff out of there, because all it's being used for is storage right now. And it's just not serving anybody, any purposes other than just sitting there. So anyway, if you would check onto that and check on the
I will.
on
Those
those
prescriptions.
prescription, because I've watched it for 6 months, and they just seem to be going up and up and up.
Okay.
And it's, I don't know if it's to be a concern about it, but just like to see what the analysis will look like.
We'll see what we can find out.
Thank you. Thank you, ma'am.
Counselor Lay?
Thank you, Madam Chairman. Connie, the third-party billing is either equal to or a little higher than 2015. Well, it's a good sign.
Yes.
You mentioned the coders and billers, and I think they're working as hard as they can. Also, probably when we expanded these clinics, and just like George says, when you got more room, if you're a doc, to go from one room to the next without having to stop and refocus or clean the
Yes.
whatever. I think that helped, and I think we're going to see that exponentially up on the hill when we get that built.
That was our goal, and that is our desire to continue that with the
The-
expansion.
And it's a good sign. Hearing aids, can I still send our patients from my district to Hastings for hearing aids? And do they get 2, or what's the?
If they need to, they will get to. I will tell you, Dr. Burkhart is an extremely busy audiologist, and he has appointments booked past a year, beyond a year. And I think he focuses on children, first of all, because they're at a learning age, and it's so important, obviously, their hearing. We're adding some staff. Brian, do you know where we are with adding the extra staff to audiology? Do you?
Have you tuned up there?
Okay, I'm sorry to put you on the spot, but we are looking at ways maybe from Contract Health to find another position and get the support staff. Didn't we add a clerk or something to help him with some things?
Yes.
Okay, That's what I was talking about, and we're looking at trying to find another audiologist.
Well, that's one of the questions. I mean, Claremore's backed up till, I think, September, maybe October by now, probably.
We're on past October.
Yeah, you're way past. I'm way behind. So we're a year behind at Hastings.
Yeah.
And help, I guess.
Yeah.
What I'm saying.
We hear you.
Thank you.
Okay. Counselor Taylor?
Connie, I also had questions on that chart on page 11. If Amy could do just a real back to basics overview on that for us. I mean, I noticed nothing's gone out on diabetic shoes. I know we're seeing people about that. So if she could do us, and I think everybody would be interested in, just an in-depth overview of that, I think I would appreciate it in addition to Harley. I had another question on the ACA. Does Salina have somebody in that position? Or
My understanding is all of our clinics have a representative in the,
Okay.
trained, at least one. I think we have 32 throughout our health system, so there should probably be more than one at Salina.
Well, it's just odd to me that they didn't take any applications, they didn't talk with anybody, and Cooey is the same way. So I was just wondering if maybe that position was vacant at those clinics.
I will check into that to see, and you're right, it is odd, because they're usually very, very, well, you can see, at least there's efforts being made.
Right, okay, thank you. That's all I have, thank you.
Counselor Baker?
Yes. Thank you. On the hearing aids, if they're out of district, do they get one hearing aid? Or are they still entitled to two?
If they're out of our service area, I believe they only get one, but I will clarify that.
Because that was, the way I remembered it, that it was only one if they
Yes, sir.
moved outside.
So,
Okay, thank you.
Any other questions for Connie? Counselor Stick?
Connie, I guess I can ask some of these questions to the behavioral health. What's your name? Who?
Cherokee.
Okay. So the people that I've been visiting with behavioral health, they say that there's anywhere from 35 to 40 people that have left the behavioral health. That included 2 nurse practitioners and 3 nurses in the last year. And so I guess my question is sometimes you need to clean house, per se. Was this one of those circumstances where you need just to clean house, or was it, what was?
we have not lost 35 employees out of behavioral health in the last year.
Well, the folks that are employed over there have gave me some statistics and data, and so
I can get you a turnover report from behavioral health now. I know about 2 years ago, we had a major change in leadership, and some people left because of the change in leadership, but then I hate that some of those people left, but sometimes, you know, it's difficult for, to hold people accountable sometimes. And when you have staff only seeing 2 or 3 patients a day, when we know what the need is for behavioral health services, then it may be best if they leave our health system, because I don't want to pay them to see 2 or 3 patients a day.
yeah.
Not with the demand. And I know you guys don't want it. You're here to make sure patients get the services needed.
With, you know, I heard you say there was a waiting list of patients needing to be seen in behavioral health.
No, sir, I said there's a wait list to get into inpatient treatment. There
Okay.
should not be a wait list to be seen in behavioral
Yeah,
health.
that's what I was referring to. So, so we're saying there is a need in behavioral health with alcohol, people addicted to alcohol, drugs, etc. Why aren't we prioritizing more of our dollars to behavioral health? I think you mentioned a while ago there was a shortage. We bring out money in behavioral health.
No, I said we've overspent. We've continued to provide services beyond what we were budgeted.
Well, that's what I'm saying. we're needing more money to be put in behavioral health because there's a big waiting list of people trying to get into our inpatient care. So, saying that, why aren't we, as a Cherokee Nation, putting more money into behavioral health to help with that need?
I don't know if you heard what I mentioned earlier, but we are looking at doing an inpatient facility and using some of our resources for that purpose. Because no one's been denied care for inpatient treatment. No one has. That meets criteria. So we're meeting the need as best we can, but we're also dependent on other facilities to have a bed to place those patients.
So we are looking at putting an inpatient facility
Yes,
in
at
Cherokee
J.
Nation. Where at?
At the vacated J clinic.
Okay. That'd be a good starting point. The other thing is been talking to a lot of doctors, and a lot of them are disgruntled as far as the pay scale, the pay raises. We've been visiting about this for the last few months. And the part that they're most disgruntled about, and I understand their frustration. When they see their leader getting an increase in pay. Well, we all passed the budget last year, and we gave yourself and some other people some pay raises.
I got a 3% raise, sir.
I understand, and that's good. What I'm saying is it doesn't set well with doctors and other staff when their leaders are getting a raise and they're not being considered for a raise because
they are being
there's
considered.
I'm just saying. I'm telling you what's being out there.
I'm just saying the doctors get up to a 5% raise every year. The minimum primary care doctor makes $160,000 a year. I think I sent this to you in an email.
I did a FOIA request and I got that information.
Right.
They're
And we're talking
underpaid.
about a pay raise for the providers that's going forward that will hopefully be on this year's budget.
Our doctors are underpaid.
We all have agreed on that.
I understand. Yeah, we all agree on it. But the bad part is we don't got the funds to.
We
pay
have found
for
a
the
way
doctors
to do it within budget, as we've been saying for the last 6 months.
due to the RVUs and the formula that you guys created. When you do RVUs,
Do you not want the docs to see more patients?
yes, but it's all by circumstance. If you got a bunch of people that's got the flu that comes in and sees a doctor, they might see 30 of those people. But if you got someone that comes in and has some serious health complications, they might see 2 or 3.
Right.
So that formula is.
I don't think you were present when we presented that plan. So if you'd like for us to explain that to you, maybe outside of this meeting,
Yes.
we'd be glad to meet with you so you can understand it. Because if you see the sicker patients, like you're describing, like a complicated diabetic or a cardiology patient, then they get a higher RVU number. But I mean, it's a lot to go into in a
Yes.
committee forum.
I'm just telling you, Connie, if I'm a director at Muskogee Public Schools, if I give myself a raise and all my staff's underpaid, and I don't give them a
Counselor
raise.
Walking-Stick?
Yes, ma'am.
This is a moot point because, like Connie said, our doctors receive a yearly increase, and they are working on a program to increase the base pay as well as the bonus system. So if you want to hear that presentation, she can visit with you offline.
Okay. That's all I have, but that's what it is. Thank you. Thank you, Chair.
Any other questions for Connie? Okay.
Yeah, one comment. We're having our 10th year anniversary there at the Wellness Center.
Oh, that's right.
And so we want you to organize something special there. There's a lot of elderly people that go there. When we sent them there, we don't send them to Hastings and use third-party billing. So we're sitting, the more and more we can get to go there, the less you have to deal with these type of issues. Preventive health is what we call it.
That's right.
So, yeah, these numbers look good, and I'm happy that we're getting more and more numbers, but I'd feel a lot better if we had more numbers coming to these wellness centers.
Agreed.
We have to educate our people a little bit more on how some of this works. I know our numbers are good, and we got to keep our numbers up to collect the funds, but, do something special for those people that come there. Would you please?
Well, if we had a wellness center in Stillwell.
Thanks.
Let's go on to the presentation.
Well, first of all, you gotta use it, even if it's there. That building's been there for 50 years. It's not something we built.
Right. Okay, you want to introduce the presentation?
This is TK. Let's do it. Come on up. The presentation.
I'm going to apologize. I do some technical difficulties. You guys are getting handouts instead of a PowerPoint, so I'd like to apologize for that. A little less colorful. Thank you, Ms. Davis. So your comment about preventive health is a beautiful segue into this presentation because that's essentially what I'm going to talk to you about. So behavioral health has just wrapped up 6 years of a very successful grant, and we just published a paper in the American Journal of Public Health about the outcomes, the main outcomes of this, and that's what I'm presenting to you about today. And I believe Ms. Cookson probably handed you guys out that article if you're interested in reading it. So if you guys will follow along, I'll just wait for everyone to get one. I apologize. If I'm one short, I'm sorry. That was 20. So this grant was designed specifically to reduce and prevent underage.
You got chief.
Yes.
Could the two council people that are really late get a copy of those?
We have one.
We
They
don't,
can find out.
we don't have enough here.
Yeah, they gave her one.
So the grant was specifically designed to reduce and prevent underage alcohol consumption. And so on this first slide here, it's kind of a list of things of why underage alcohol consumption is so bad. Homicide, suicide, risky sexual behavior, which then goes into teen pregnancy, preventive health issue, right? And one of the biggest issues is brain development doesn't stop until you're 25 years old. What that means until you're 25 years old, that you're not able to inhibit things and you don't make the most sound decisions that you can make. And therefore, when you throw a wrench in that development, it's going to be a lifelong impact along the line. And so this next one, this graph here, and I apologize because things didn't print out well, what you're looking at is on the left-hand axis, the y-axis, which is the percent of anyone who's ever had an alcohol dependency. Along the x-axis should be age. And so it's going to be youngest age going to oldest age. And what this graph essentially shows is the younger that someone starts drinking, the more likely that they will ever have an alcohol dependency issue within their lives. Okay, so what you guys can't see right around here is 18 years old, 19 years old. Okay, we're probably not going to eliminate it, but if we can reduce or prevent or delay the consumption of alcohol use by our youth until they reach college or 21, the reduction in their ever having an alcohol dependency reduces by about 250%. That's pretty substantial. So this project summary is a partnership between university prevention scientists. They were some are at the University of Florida, some are at Emory University, some are at the University of North Texas. And like I said, we're to prevent and reduce underage alcohol consumption. And so the goal was to implement two very rigorous evidence-based alcohol prevention strategies. And so this all happened within the TJSA. They only had one of these grants out every 10 years, and we were lucky enough and competent enough to get it. And so we wanted to apply that every bit of it within the borders of the Cherokee Nation. So the research design on that is we selected about 20 schools, and then we compared all those 20 schools on a number of factors. High school enrollment, did they have a Walmart? Percentage of students on free and reduced lunches, percent of American Indians within reported in the school, within enrolled in the school, in addition to the total enrollment. Randomizing this statistical stuff, put the four closest together, the ones that were the four most alike across all the demographic factors, and selected those so we could be more certain that our intervention was actually what's causing the success and not anything that was extraneous to our efforts. So what we got is one school got one intervention, one school got a second intervention, and then one school got a control, which didn't get anything until the end of the study where we knew what worked the best, they would get that. And then another school got both of them. And then in the second year, we added a school to the controls, and we added a school to the double the combined intervention. So 2 schools got the combined intervention, and 2 schools got the delayed. So, and how we tracked this was through quarterly surveys and a controlled intensive longitudinal design through some alcohol purchase compliance, and then these quarterly surveys. So we gave student surveys about every 3 months or a little bit short of that. So students were surveyed 4 times every year. And this is novel because a study of this size that does survey collection in that much close to real time has never been done before. And we made it work. Normally, studies like this only give a survey once every year. So the data is not as up to date, and it's not as actionable in terms of time. So, yes, sir.
How accurate do you think the survey was from kids?
So I don't want to bore you with all the research because I'm a numbers
Well, I
guy,
mean,
but so the surveys did in fact track students across time. We had to, right? So if you want to see change over time, I have to know that you fill out this survey and this one, and I have to link them together. So students did not put their names on the surveys. They were specifically instructed not to, but they were linked with a unique identifier. And that unique identifier was printed on every survey. So what the research shows is that anonymous surveys where you are not linked at all, where you just write down anything you want, there's no way to tie it back to you, and surveys in which kids are tracked across time, there is not a difference in the amount, in what is shown in the validity or the dishonesty. They're very similar. So if kids rely on the anonymous one, they rely on this one, but the chances are they're going to both be honest at about the same rate given both types of surveys. And I will tell you, in one of our towns, we had a big uproar about one of the daughters from one of the coalition members was very worried about the tracking and stuff. And so we made it very clear to the students that the only reason we would ever breach their confidentiality is if anyone reported any self-harm or harm to others. In fact, we obtained a certificate of confidentiality from the national government where we could not even be compelled legally to divulge their scores or their answers, just to take that extra step to try to garner very honest feedback from these students. So this is the slide I'm on here, and just now talk about all this, but what I want, we put this slide in here to demonstrate how it takes a village to kind of raise these children, right? So you have prevention scientists from all over the nation come to behavioral health, and it's not just us imposing these things on communities, it's us working with these communities at these levels to include everyone in these changes, because these changes are not going to be successful unless you impact the whole community and get the entire community as a united front. So one of the interventions is the CONNECT intervention, or what we call the CONNECT intervention. And so what this is a universal screening and brief intervention, and then a referral to treatment. And so the goals of this was to provide in-school support for the students, and then it was supposed to increase motivation for students not to use alcohol. And essentially, a large part of this is to shift norms and cognitions around alcohol. What the research says about how many kids actually use alcohol is much less than what kids actually think kids are using alcohol. And if you think someone does, if you have a norm where you think most people do it, you will be likely to engage in that behavior. And so part of this is to educate the students about the norms that most kids don't drink, so then they'll follow in line with that, because norms are very important for all of our behaviors. So then the goal is to ultimately reduce and prevent underage alcohol consumption. So the CONNECT coach, we worked with Department of Human Services. There was a program where if they paid for half of their salary, we would pay for the other half, and they would be in the school full time. So DHS got half their time to do in-school social work, and then the other half of the time, we got them to do this CONNECT coaching where they have these interviews with these students. And then we also had a media campaign that went with this to try to promote that changing of norms and culture throughout the entire community, and not just with the students, because we have to reach the parents too. And so this slide right here, this is a copy of one of the postcards that we sent out. And so what we try to do is promote positive images and positive relations between parents and students. All these images were approved by community members before we sent them out, because we wanted to make sure that they were applicable and culturally appropriate for those communities. And then they also had positive parenting tips. And so you can kind of see some of those there. So the accomplishments of this particular intervention is 73 to 100% of eligible students at least had one session with this CONNECT coach over the 5 semesters that these coaches were in these schools. So we sent out 10 postcards, and we also displayed some posters throughout the community to try to get that community involvement and demonstrate what we're doing in the community, and so to engage the community as a whole. So the next intervention is CMCA, and this is Communities Mobilizing for Change on Alcohol. The gentleman who developed this intervention actually is the husband of the PI on this project, and he worked very closely with us. We felt very lucky to have the original designer of this come in and work with us, because we knew we would get the best at what we were doing. So the goals are reduce alcohol sales to youth, right, and that's retail access, reduce social sources of alcohol, That's people you know old enough to purchase alcohol for you, whether that's college friends or your parents or siblings, whatever the case may be. And then reduced tolerance of underage alcohol consumption. That's what I'm getting back to the social norms, is you want to change the community perception or the acceptability of it's okay to drink when you're underage. It's not a rite of passage. So once again, reduce that consumption. So some of the strategies were, and they were all evidence-based strategies. So commercial sources. So we collected data on how the commercial sources were selling to individuals who appeared underage. The social sources, we attacked social hosting, and we really tried to get officers to enforce certain things like hotspot policing and go in to check on parties. So if you heard there was a party on Twitter, please go check that out and try to police that. So the implementation of this particular strategy, letters to the editor, op-eds and social media, all that came from the community. So we had one community organizer in the community. They lived in that, most of them lived in that community. We had an individual, Locust Grove was one of our communities. We had a lady in Pryor. She actually did all of her school shopping, all of her Christmas shopping, as much as she could do in Locust Grove to develop a relationship with the Locust Grove community, and she would talk to them so she could make a presence there and wasn't just an outsider coming in to do something and then leave. She made a big effort to organize that community and have a relationship with that community, and it was very effective. So law enforcement strategies, reporting the parties, social host enforcement, actually enforcing social host reports, and then we obviously work with the vendors to try to ensure to reduce that commercial access. So the results, there's two points of results or 2 points of data that I'm gonna have. The first one is this survey. And so we looked at past month heavy alcohol use, and then past month regular alcohol use, and then other drug use, marijuana, tobacco, prescription drugs. So we did 12 survey waves over 3 years. Like I said, 4 a year for 3 years, 12 surveys. And so what we did is we tracked the same kids all the way through school. And so when the first kids started, they were in the 9th and 10th grade. The next year we surveyed those same kids in the 10th and the 11th grades. And the next year we got them in the 11th and 12th grades. So that way we could track their development across time and have the same kids, so it was a within student change. And we received response rates that were phenomenal. If any of you are familiar with some of the prevention strategies and prevention surveys out there, the YRBS and the OPNA, the response rates are not nearly this good. But I will admit to you that we paid every student $5 in cash every time they took the survey to entice them to continue to participate in our surveys. Because it was the exact same survey every time. And believe me, they were not necessarily happy about it, so we had to find a way to keep them engaged and keep them giving us good data. So the demographics of the individuals we surveyed about 1,623 high school students. Gender was balanced, or sex was balanced. Average age at baseline, right, 9th and 10th graders was 15 years of age. 46% reported Native American, 80% of that 40% reported being Cherokee, and 22% reported being Native American only and not of mixed heritage. 46% reported white only, and then about half receiving free or reduced price lunches. So I'm not going to read all this off to you guys because you guys have it in front of you, and I hate if you can read stuff to me that I can see myself. But these are the impacts that we had based on these interventions. These are some pretty substantial numbers. These are some pretty good impacts. And when you talk about preventative health and the impact of how behavioral health has this huge demand, it starts at prevention. This is how we reduce demand over time, right? It's starting at the base. And so this is very, very important, and I just want to draw your attention to how important that is. So the next one for data collection is for alcohol purchase attempts. Quick question, are any of you, ladies or gentlemen, familiar with compliance checks that our prevention department does? Like they will send an underage individual into a store to buy tobacco or alcohol, right? Police go with them. If you sell, you get a ticket. If you don't sell, you get a pat on the back to try to encourage you to continue to sell. So our alcohol purchase attempts were a little bit different because if we sent someone underage in there and they purchased, a crime has been committed. And so what we did is we hired specifically females to standardize protocol. They all had to look under 20 years of age. We took them to Walmart. We asked 20 random people how old they looked and how old they thought they were. And the average age of the perception would have to be averaged out to under 20. So 19.95 and lower, you were able to come purchase alcohol for us. If you didn't make the cut because you looked a little bit older, we couldn't hire you. And so we sent these young ladies into stores, every store in the community, once a month, and asked them to try to buy alcohol. So if they were sold to, they shouldn't have been, right? Because you're supposed to check ID, and you're not going to sell to them because these girls didn't have IDs. They weren't allowed to have IDs on them. So there was no way for them to think they were doing a good job by presenting their ID and by buying a lot of alcohol. So the mean number of alcoholics per community was 21. And so this is something that I want to also draw your attention to right here to these numbers. So the baseline alcohol purchase attempts, this is just the first 10 alcohol purchase attempts, okay? And we're talking over 1,000 attempts, okay? 23% resulted in an alcohol sale without an ID. So they either just sold the alcohol outright, the young lady kind of fought for it and said, oh, come on, I'm 21, or said, hey, my birthday is, and rattled off a number and the person put it in and just sold to them. One less, no fuss. And so working in these communities, and I think you guys have probably heard these perceptions given your positions, that there are certain places that people feel are problem places or problem areas. And I'm not going to tell you that that's not true. But I will tell you that 76% of all the outlets on our list sold alcohol at least one time to someone who did not appear over 21. Now we've looked at the full data across all 36 waves. That number jumps to 95%. So I'm going to go back to talking about it's the entire community that we need to engage. We got to change the perceptions of all the community, because even these mom and pop shops and these big retailers, 95% sold at least once to a kid who should have not have been sold to, or a young lady. So this is just a graph to show you how effective that was. What you're going to see, the darker line is going to be the control. What that means is they did not get intervention. Right? So you stay stable over time. The lighter line is the control, and you can see how the alcohol purchase attempts started to decrease over time through the effects of the community intervention, where the organizer went out and tried to rally the community to prevent this retail access. So the last thing just to talk to you guys about is just how successful this was in reducing alcohol among American Indian and white rural high school students. And this for me is extremely important, because about, I think based on the statistics of enrollment, only 35 to 40% of the Cherokee Nation within the TJSA are Cherokee. That means the majority statistically are not even tribal members, right? And so when you impact a whole community, that's extremely important, because if we only impacted the Cherokee kids, we send them right back in out to a community that's predominantly not Cherokee. And so it's like behavioral health for perfect example. We get them for 50 minutes and we send them right back in the environment that probably caused their problems for a whole nother week. So the only way to make long-standing, substantial changes that will have an impact on our people for long-term, preventative health, reduce behavioral health demand, is to affect the whole community. And that's a beautiful thing, because it works. It's a universal strategy, and it works very, very effectively to impact an entire community. And it's also relevant and responsive. Based on the conversation I've just heard about behavioral health, you guys questions from Ms. Davis, this is hugely important stuff, and it's very pertinent to what we're currently dealing with in terms of talking about addictions to alcohol. We're also publishing a paper now that talked about just the range of the impact across marijuana, prescription drugs, and how those were negatively, their use rates were reduced as well. And the last thing I just want to talk about is just how much we're trying to do with this. It wasn't a bunch of university researchers just coming in, collecting data, and bouncing out and leaving us. We're working currently to get this on NREP, which is a National Registry of Evidence-Based Prevention Programs. I know our prevention department uses this quite a bit. People all through the nation, SAMHSA, NIH refer all sorts of grant applicants to NREP. For us to be on there and to have that done in Cherokee Nation is a very prestigious thing, and we're very proud of that. CADCA, we're trying to present CADCA, change some of the coalition perceptions, because we feel that coalitions have some detriments that community organizing does not. And we're very excited about trying to somehow dovetail or integrate those approaches. And so this is very successful collaboration between us and CADCA. And finally, I was just told today before I came in the meeting that the Hilton Foundation has called the PI at Emory University is so intrigued with this intervention that they have thought about, they want to find out a way to fund this intervention to the rest of the Cherokee Nation. So we hit 6 schools, and we got a call saying, how do we hit the rest of the nation? And so obviously it's going to be fairly expensive, but it's more inexpensive than a lot of strategies are. The cost breakdown is about $55 a student for them to get a community intervention. And so one of the things we would like to talk to you guys about in the future and see what we can do with the Hilton Foundation is to how to work with Cherokee Nation to get those funds together, to give all of our students this kind of benefit, early success in life, moving towards and being successful and not having alcohol dependency. So I really appreciate your time. I assume I've gone over. I apologize, I'm passionate. Thank you for your patience, and thank you for your time.
You might add that this was
Yeah,
published, and $55 per kid is a lot cheaper than 28 days in rehab. I can tell you that for sure.
28 days, right?
It's
Contract on
very
that.
interesting and very successful. We appreciate your time. We have just a few minutes for questions, I believe. Counselor Crittenden.
Yeah, I'm sorry.
Thanks for this. I'm just trying to understand it. It was a grant that funded this.
Yes, sir. It was an NIH, it's an R01 grant from NIH, and if I'm being honest, those are the gold standards, and it's the most prestigious grant in the research world.
And us doing this will possibly open up other avenues for grants.
Yes, I mean, so they, as far as I understand from NIH, randomized community trials they'll no longer be doing, so we were the last ones to get one. But it will open up other opportunities for other grants. And the fact, if I'm being honest, because one thing I heard when I first started working at Cherokee Nation, as a researcher, it was always, yeah, it works, but does it work here? Right? That's everything I always heard, but does it work with Cherokees? Does it work with our people? Well, you know what? We just found something that does, because we did it here. Right? And so people like the Hilton Foundation and CAPCA and NREP, they are interested and they do want because if it works for us, there are 5 million other Native Americans in the United States.
Just the bigger pictures, it can open up doors for more money to help, right?
Yeah,
because we're discussing that there's a wait time on the so we've got to work hand in hand. I mean, this data was great, hard work, and I appreciate it, but really no surprise to anybody who was raised around here. You know what I mean?
Yeah.
But to get the funding you were talking about, we've got to look at the J thing and that before that all comes together. But I appreciate what you were doing, and heck, we can get some more money and get in line with Connie's crew to get some more of those facilities. This was here's what's going on now. But what can happen now is I see that as one of our biggest goals is to get help, because they need help.
Well, they've proven that we can make a difference. And we've got the tools now, we know what's worked, it's proven scientifically, and our public health educators can go forward. But it also takes you guys, putting pressure on your local communities for the vendors who sell alcoholic beverages to not do so.
Well, we look forward to a follow-up with the Hilton group. Councilor Berg?
Very good information, Been involved with the health committee and behavioral health for a long time. I'm not sure we've ever had this type of data.
We have not.
Some of the information may not have been surprising, but at the same time, you got to have good data. You got to know where the issues are, where the obstacles are before you can address this. And you showed it in different ways here. The only thing is sometimes I liked your percentage here. You're 46% Cherokee, then you went whites, I think those are the words you used, and then a certain percentage of probably other tribal members here in our area that we have. A lot of times what they like to do at the national level is lump us with tribal members in the 50 states. And it depends on whether you want to show a bleak picture or a fairly good picture. If you were just to show the 5 tribes, you could probably get a better picture. If you want to include reservation tribes, Cherokee people, you'd get a little bit more of a bleak picture. I've been involved in writing grants for a long time. You can give the federal government what they want to hear, what they want to see. But really pleased with this report here and look forward to working with you in the future. You're an outstanding job with this research.
Thanks very much. And to corroborate what you're saying as quickly as we sat down with every school administrator every year to give them the data from this survey, because we wanted to give it back. It's their data, and we wanted to allow them to use it. I mean, we're not here to just take it and run. And I can tell you that for most of our schools that we compared that data with the region, right, the YRBS, Cherokee Nation YRBS, the state YRBS, regionally, and nationally. And most of our schools were actually under on most of those estimates for alcohol consumption, tobacco use, marijuana. So what I don't want to say is that doesn't mean we have a problem, right? Because use of any of those things is problematic. But you're right, in terms of how to present that picture, I would like to inform you and corroborate what you're thinking is most of those schools were actually under the estimates of those larger regions.
Sure. Well, good, but very good. Very good.
Sir, I appreciate it.
Councilor Hatfield?
This is great information. Okay, basically, did you just survey the students? You didn't say that you spoke with parents or anybody. You didn't have any interaction with the homes, visit homes. Basically, you just did a survey with the students in their school, in a school setting. Is that what you're saying?
So Data collection could not be associated with the interventions, because once the students know why we're surveying them, it's going to change how they respond. So my piece, I was a director of evaluation, so I know the data better than anything else. But the interventions, the community intervention did impact everyone. Like, so we sent those postcards out to every student's parents. So we didn't necessarily go to their homes, but we reached out to the community. The community organizer was out there talking. I think we did 700 one-on-one talks in the first 3 months of community organizing within 6 communities. 3 communities, because we only had community organizing in 3 of them, right? So yeah, no, they were out in communities. They were doing things. They were having get-togethers, parades, rallies, things like that, hanging stuff up. A presence at football games. That was a huge thing. And so the 2 control schools that did not get interventions, please know that in the last year of the grant, in which we found out how effective the community piece was, we had hired another community organizer and sent both of them out into the remaining schools to have that community presence and reach that whole community. So it wasn't necessarily just surveying the students. That was the way we determined the effect. Right. But there was much more interaction at the community level, and that was much broader.
Okay. Very briefly, Stick. Very briefly, because we're already over time.
What was the percentage of surveys that you received back?
So we did wave to wave, right? So we had 12 waves, 4 year. And so the response percentage, or the percentage of responses, varied from 83 to 90%.
Wow.
We did have, if I'm being honest with you, we were very excited. Prior to junior high, 1 semester, 1 wave had a 97%. It was phenomenal.
That's really good. So the intervention that you were talking about, is this a curriculum that you guys were doing, or?
I wouldn't call it a curriculum. It's a manualized, research-based, evidence-based prevention strategy. I don't want to call it a curriculum because I think that gives it short shrift. It's legitimately, it's very research intensive, and they've done this intervention in Chicago, in the inner cities of Chicago. So it's been tested with a number of different cultures and brought here and found to really generalized.
So you won't be able to tell if it's effective or not until you survey them next year, or a couple years down the road, to see the effectiveness of the intervention.
Are you talking about, maintained effect and sustainability?
Yeah.
Unless we survey those kids today, I can't tell you if the intervention itself has maintained or sustained over time. What I can do is draw those correlates between other research that says if I can delay you from drinking from 14 to 18, that the likelihood that you'll have an alcohol dependency goes down by 250%. And so knowing that we've reduced alcohol consumption by the percentages that you see in that slide, I can't give you a definitive answer unless I survey those kids today. But I can tell you with some pretty good certainty that a lot of kids are probably not going to have the alcohol issues they would have had we not been in those communities.
Yeah, I worked in Muskogee as a drug and alcohol preventionist, and we did the surveys and the curriculum and everything, and it's exhausting.
It is.
But the biggest problem was at home. The home seemed to be the problem, and we all can relate because we have communities and we see these families. But anyways, I don't want to take any more time up. But this was good information, and I commend you for this.
I don't want you to leave here thinking this intervention wasn't effective.
No, I think
it was very effective.
Yes.
It was super effective. I just couldn't tell you if it was a sustained effect.
Yeah, no, I'm not doubting it. I think you've done a great job with this. So appreciate you.
I'm sorry.
Thank you, Chairman.
Thank you. And Terrence, we thank you for your presentation. I guess we'll move on to announcements. The next meeting is tentatively scheduled for Tuesday, August 15th at 1 o'clock.
Make a motion to adjourn.
Second, all in favor?
Aye.